Sebastian, thank you so much. It's a great pleasure and a great honor for me to be again here in Lyon with my French friends. So again, thank you for the invitation. My topic will be about serology, hip aspiration, bacteriological samples, and histology. And I will add in my current practice, I will not give a theoretical lecture on all the tests, you know there are a lot nowadays, but what we do every day in our clinical practice. These are my disclosures, which are not related to the content of this presentation. Prosthetic joint infection is a problem. Infection after joint total arthroplasty can present a diagnostic challenge. No preoperative tests are consistently 100% sensitive and specific. This was by Spangeli 25 years ago, but this statement is still true. We know that the diagnosis of PJI is multifactorial. It includes history, the patient, the risk factors, or whatever, imaging, but it includes mostly the topic of my presentation: blood test, joint aspiration, culture, and histology. Let's start with serology. What do we do routinely when we see a patient with some suspicion? We go for ESR and CRP. This is for everyone. They have high sensitivity, more than 91%, especially the CRP, but unfortunately poor specificity, even with the low cutoff in the CRP. Then we use nowadays the D-dimer. There is some controversies about this. The sensitivity is high, the specificity is not so high. It outperforms ESR and CRP in low-grade chronic infection. This is the patient when we use it. Then, as you know, there was a worldwide race for biomarkers, sometimes linked to business. We must honestly accept this. And most of them are not useful in every day, and most of them are for research. For example, we did a study on calc protein on the synovial markers. It works, it's interesting, but unfortunately, it's not for routine yet. Then the next step is joint aspiration. We do not aspirate all the revisions, but just selected ones, which is around 50%. That means the ones that have elevated CRP or ESR. In all the patients, of course, with clinical suspicion of PJI, in case of unexplained chronic painful prosthesis, in case of uncertain early implant loosening, and before a revision, when we know it's septic, when it can influence the therapy and we don't know the back, just to identify the pathogen before the first stage. Its aspiration, unfortunately, have a major limitation. The major limitation are the dry joints, which are around 1 out of 3 of them. Lavage is controversial, sometimes do, sometimes some others don't do. We don't do nowadays lavage because it can create false positive. The culture is very important. It must be done in very aseptic condition because the worst situation is when you have a false positive, of course. Fluid must be placed in vials, avoid swabs nowadays. If the patient is medically stable, even if infected, withhold any antibiotic therapy for at least 2 weeks prior to the aspiration, and incubation time is not less than 2 weeks. It has high specificity to confirm the pathogen, but unfortunately, a negative growth does not exclude the PGI. And in case of high suspicion, repeat 2 or even 3 times. A suboptimal sensitivity, around 70% in the first aspiration, is due to the biofilm and the sample accuracy, which is not so easy, especially, of course, in the low-grade infection. We improved a bit our practice with this. This was a study that we developed and the technique we developed in my hospital. When there is a dry joint, our radiologists, under ultrasound, they go with this technique of biopsy of periprosthetic synovial tissue to rule out the PJI. That means that the tissue, the samples, are sent for culture, as we do during surgery. This improves, but again, that's not 100%. The test that we had to do for all the cases with very good result, it's about white blood cell count and neutrophils in the synovial fluid. More than 10,000, or this one study says more than 12,800 at 6 weeks, with more than 90% of neutrophils is suggestive for acute infection. For the chronic, there is debate. Someone says 2,000. In the consensus, we have 3,000. A lot of studies say it's too high. It's between 2,000 and 3,000 cells with more than 70% of neutrophils. This is chronic infection. Then we have some tests that we can use. The most famous one are alpha-defensine and leukocyte esterase. They are available fluid markers. They identify PGI with comparable one to the other diagnostic accuracy when you use the ELISA test for the alpha-defensine. But it's not easy for us. It's expensive. It's time-consuming. So now we use routinely leukocyte esterase, which is an enzyme secreted by activated neutrophils that have been recruited to areas of infection. It has a high specificity, positive and negative predictive value. You just need a heuristic used for synovial fluid. It's simple, it's a cheap tool. We don't do by ourselves, but we send to the laboratory. The results is in 2 minutes, but sometimes when there is some blood contamination, it needs centrifugation, which is 10 minutes more in the pre-op phase or during surgery, where it is very useful, of course. And of course, there are intraoperative tests, which include the bacteriological samples and the histology. The cultures, again, the technique is very important. 5 or 6 samples, at least 4, of fluid in vials and of tissues, no swabs. Change the gloves, avoid manipulation of the fragments. When we took a fragment and for any reason it went to the table, we waste it, we don't send it to the laboratory. This can be a false positive. Incubation time, not less than 2 weeks. 2 or more positive indicate PGI, with the same bacteria, of course, according to the criteria. Then we sonicate all the implants that we remove, as we do the samples in all the revision, even when we have no suspicion of infection, for example, in a periprosthetic fracture. The removed implant is sonicated. It dislodges the bacteria from the biofilm, then it's cultured. The sensitivity is higher than a single sample, and it becomes very high when it's combined with histology. Frozen section, histology intraoperative, was the gold standard in the past, even for us. 3 to 6 samples, the number of neutrophils per field 5 increases the sensitivity. It's high, 80%, the specificity is very high, 90%. But there are several limitations. You need an appropriate sampling, the surgeon, it's you, so it's easy. But you need a skilled evaluation by a skilled pathologist. If you don't have it in the hospital, you have to call him. Maybe, if you want to do it intraoperative, it can be complicated. And in low-grade pathogen, there is a scarce inflammatory response. It's time-consuming, need to be properly organized, and means also increased cost. And when you look at the definition of PGI of the Philly consensus, it says the same value of leukocyte esterase intraoperatively. So what we do now, we did a study when we compared leukocyte esterase and histology, and the sensitive was higher, similar specificity, and diagnostic accuracy compared to frozen sections, at least in our hands. So we stopped frozen sections nowadays. In conclusion, ESR and CRP in all the cases, D-dimer in suspected chronic low-grade. Aspiration in all suspected cases. Ultrasound biopsies has improved the accuracy of joint aspiration in dry hips. Bacteriological samples in all the revision. Leukocyte esterase in conjunction with white blood cell count and neutrophils has replaced frozen section intraoperatively because faster and cheaper. This is in our practice. Thank you so much for your attention.